Welcome, everybody, to our very first Ask the Experts. Today, we're greeted with Outi Uimari. If you want to tell us a little about yourself and, how you got involved in the HLRCC community.
Hi, thank you so much, Jason. So I'm Outi Uimari from Finland. I work for the University of Oulu. I'm a clinical doctor. I'm a specialist in obstetrics and gynecology. And over 20 years ago, when I was still at the beginning of my medical studies, I approached a gynecological professor, Markku Ryynänen, with an interest to do a PhD thesis on some of the gynecological areas. And he suggested a project on uterine fibroids. And it took some time, and I finished with my PhD thesis in 2017. But prior to that, I also started my postdoctoral studies when I worked for the University of Oxford in the UK for 3 years. And currently, I run a research group that focuses on uterine fibroids and also endometriosis, which is a common chronic pain condition.
How many HLRCC patients then have you worked with over the years?
I've met only a few. It's a very rare condition, and I work here in the northern Finland. The population isn't huge, but I've diagnosed I think 2 patients. But for my research project that I made plans with Outi Uimari back in 2007, I think. We gathered all the Finnish HLRCC women having fibroids and having hysterectomies due to their fibroids, and I've reviewed all their medical histories. There were about 20 women on our paper. This paper was published in 2021, I think, where I reported the clinical picture with these fibroids, and I compared them to sporadic fibroids.
Okay, so what can you maybe tell people about the key clinical differences or pathological differences between the FH-deficient fibroids in HLRCC and I guess the more conventional sporadic ones that you usually read about in the literature?
Yes, women with HLRCC-related fibroids are quite different. They're much younger when they're diagnosed, and they have multiple fibroids, so 10, 20, or 30 fibroids. And women become symptomatic with these multiple fibroids, but when a gynecologist does an ultrasound scan, the fibroids, they seem a bit different than the sporadic fibroids because they're smaller and there's so many of them in the uterus. And having tens of fibroids in one's uterus, you become symptomatic with the bleeding, menstrual bleeding patterns, and with pain and pressure symptoms. And these women have required hysterectomy at much younger age than women with sporadic fibroids.
Yeah, and so when you say earlier diagnosis, I believe the literature says around the age of 30 as opposed to the age of 40 with sporadic, but that's diagnosis. When do the symptoms can start for some of these patients?
Right, and when do these tumors start to grow? When there is the 1 and 2 and 4 cells, how the tumor starts to grow? We don't know that. And I guess nowadays, when gynecological ultrasound examination is more available, then the diagnostic age can be even younger, compared to, 20, 30 years ago. So yes, but roughly the age of diagnosis, I'd say it's 10 years or even more.
Yeah. And so when you talk about the symptoms, like things like heavy bleeding or discomfort, I think a lot of people think this is just oh, that's a bad period. And how bad are these symptoms for these patients, would you say?
Right. So yes, this is very, it's very difficult to judge, what is normal menstrual bleeding and what's abnormally heavy. I guess one sign could be that you need to go to the toilet to change your pad, or if you need to be using the night pads during the daytimes, or if you become anemic so that your hemoglobin level drops. So these kind of an issues. And if they usually the heavy bleeding is only during the first day of your menstruation, but if it's abnormally heavy, then it continues for several days or longer in terms of days, because usually menstrual period lasts maybe 3 to 5 days, but heavy menstrual bleeding, it could be up to 10, 14 days. So up, half of your month you'll be bleeding. So that's definitely abnormal.
Yeah. And so even though like the underlying cellular mechanisms and pathways are different than the sporadic, and most of the research is done on those sporadics, how much can people with FH-deficient fibroids use that literature to inform treatment? Is there a difference as far as that?
Right. I just checked the literature today for this interview, and unfortunately, by to date, we don't have scientific evidence if they are different. It's a good claim that they behaved differently, because the driver mutation is different from sporadic fibroids. But today, the treatment options are the same.
Yeah, with the sporadic, you see how they're sensitive to the sex hormones, estrogen and progesterone. On our group page, we definitely see, obviously, the FH starts after puberty, usually diminishes after menopause. So you can assume that these FH deficient ones are also sensitive to the sex hormones. Is that a true statement, would you say?
Yeah, I can't say that it's a true statement because we don't have the strong evidence, but empirically, I'd say so. But on the other hand, I need to say that because most of the HLRCC women have required hysterectomy, or the gynecologist recommended at earlier, we don't know how these fibroids behave after menopause. So that would be interesting to explore and really to find out.
Yeah, because I think it was your paper that said 79% of women get the hysterectomies or myomectomies. So yeah, there aren't that many that make it to menopause. Also,
yes, exactly.
if I understand correctly, fibroids secrete their own hormones as well. And so what are the consequences of having like 20 fibroids, some of them very large, secreting all these extra hormones, both locally, and do they affect the body at all systemically?
Yes, that's another very good question. So we don't have evidence of that, but I know that Dr. Outi Uimari and Professor Lauri Aaltonen, they've looked at this with sort of wide eyes. So there's, on the contrary, there's no evidence of, for example, breast cancer that's estrogen dependent. These women are being at risk. So my assumption is that they don't affect systemically. But again, the studies have fairly small sample size because it's a rare condition. But hopefully in the future, now that having the alliance and more interest on this, we can put our efforts together and hopefully we'll have answers to all these questions in the future.
Yes, hopefully, for sure. As far as we got a lot of questions about how particularly women child-rearing age, if they want to go on birth control, do you have any recommendations as far as the types, whether they're hormonal or non-hormonal?
Yes, I would recommend hormonal because that impacts on the endometrium. So the fibroids themselves don't actually cause the symptoms, but they cause the pressure to the surrounding myometrium and the endometrium, and they sort of function abnormally. The blood vessel diameter is larger in a uterus where there's a fibroid, so the myometrium, so the normal myometrium next to the fibroids, and the vasculature has abnormal function. So with hormones, we can have effects on the endometrium, and many women experience reduced menstrual bleeding with hormonal treatments.
Okay, good. And then aside from hormonal therapy, there's other pharmaceutical agents that you can use to help control the symptoms and the size of the fibroids, things like the GnRH agonist or antagonist or the anti-fibrinolytics. Can you say anything about them? I know there's not much data as far as FH deficient, but are these possible ways of avoiding surgical intervention, at least temporarily?
Yes, in general, I would say about fibroid treatment, it's really a tailored treatment plan. So I would recommend you to go see an experienced gynecologist and telling them your symptoms, your wishes, and obviously your gynecologist would know your name, whether you wish for pregnancy or whether not. So that really directs your treatment. Because it also depends where you have these fibroids in your uterus. And we know that not all patients get good outcomes with hormonal treatments. And, your gynecologist would then proceed to the next phase treatments. But we know that many women in the end do require surgical treatment because the medicinal treatments aren't good enough for them.
Yeah, and I know a lot of our patients are familiar with myomectomies and hysterectomies, but there's also things like uterine artery embolization or focused ultrasound. Where do they come into the mix as far as options?
Right. So I didn't find any publication on uterine artery embolization, but there was actually a paper on high intense focused ultrasound. Let me just quickly browse through. So with a 3 years time, 90% of HLRCC women with fibroids required a re-intervention. So the treatment wasn't unfortunately sufficient for them. So that's quite a high re-intervention. But 3 years time, yes, it's a long time if you can postpone your surgery that long.
Yeah, and as far as myomectomies, sometimes people require multiple. Is that because of new fibroids or those ones that were taken out are regrowing? And what's the time span usually between repeated myomectomies, if you can recall?
Right. Yes. So myomectomy is also abdominal surgery. So it's significant surgery. And again, I would require relying on your gynecologist who reviews you personally, because the challenge with HLRCC-related fibroids is that they're so multiple. And, myomectomy means removing one tumor or only the tumor tissue. So what's the aim of the myomectomy? If you wish to conceive, what is left of your uterus and your normal myometrium? And there is always a risk for abruption during pregnancy after myomectomy. So myomectomy would be a better choice if there's only one or two fibroids. But if you have 20 of them, it's not realistic to have them all removed. And it seems that FH-deficient fibroids, they sort of all grow within the same pace or same size, so that the size do not really vary between 1 centimeter and 10 centimeters, but the uterus is just full of these. Approximately the same size. That's the impression that I have, at least.
Yeah, and so as far as then patients' timing when maybe to get a myomectomy, assuming they're being scanned annually and they can kind of see the progression, is it something that's easier to do surgery on when they're a smaller size as opposed to when they're larger and there's more risk of bleeding or complications?
Well, strictly answering to that question, yes, it's easier when it's smaller. But what's the aim? If the aim is to keep the uterus, and if you wish for pregnancy, then what are the risks involved? But if you've completed your child number, then because I'm not sure if removing 1 or 2 or 3 fibroids make really a big difference. And if you're a postmenopausal, significantly symptomatic, you've gone through all the hormonal treatments, then I would rather recommend a hysterectomy.
Yeah, and because so many of us get hysterectomies, it's hard. There's like, they usually recommend like 6 weeks of no heavy lifting and just rest. That's not easy for a lot of patients to do based on just their work and whatnot. How important is taking that time post-recovery, and what are the consequences if you try to kind of do too much too soon?
Right. So this really depends on what kind of hysterectomy you had. If you had laparoscopic hysterectomy, because it's really about the abdominal tissues and the size of the incisions and how the tissue is healing. So after laparoscopic hysterectomy, the healing times is 2 weeks or 3 weeks, of course, depending on your adipose tissue, subcutaneous adipose tissue, how quickly you recover, how physically are you active, what you do, is your work physical, do you have heavy liftings or just light office work? And it's a different case if you had an open surgery, so a laparotomy where your skin incision was much larger. So then, the healing time is longer, and I recommend you follow the instructions that you're giving at the center where you had your operation.
Yeah, because risk for hernia would increase if the abdominal wall weren't to heal appropriately.
Yes, hernia, an infection, some bleeding, hematoma might be there, and then the infection risk raises as well. So those are the most common. Yeah.
And so for larger fibroids, assumably an open surgery would be easier to remove those larger ones. There are some cases, I guess, where you can do laparoscopic, but you have to kind of, I think it's called morcellation, or you kind of pick apart the fibroid and take it out. I know a lot of patients, they feel like there might be seeding of the fibroids and they spread to other areas of the abdomen. We've had some with it in their lungs. Is that a common thing, or is that more of an HLRCC problem that you know of?
I think nowadays it's very rarely done here in Finland. I've heard that there's been a few cases in the US where a suspected benign fibroid has been a malignant leiomyosarcoma that was spread due to the morcellation. But surgery is always tailored treatment, and it goes along with the operator and the facilities and what are the what are the protocols. So you need to, I think you need to rely on the clinician who will be operating you and rely on their recommendations. So there are differences, a big multifibroid uterus. Yes, when it's really big, it's impossible to remove laparoscopically, or sort of middle size, roughly said, you can remove the uterus, but then how you can't, how do you remove it from the abdominal cavity? So one of the laparoscopic incisions is just extended, and then the uterus is removed. Or if you've had normal vaginal deliveries, then your uterus can be removed laparoscopically, and then it's the whole uterus is removed vaginally. But it really depends. There's multiple factors to this, yes.
Right. And as far as hysterectomies, then there's different amounts you can take out, where you can take out the whole uterus or other reproductive structures like fallopian tubes or ovaries. What's the determining factor of how much they take out with a hysterectomy?
Right. So about the ovaries, if you are perimenopausal, postmenopausal, then your clinician will judge whether there's a benefit of removing the ovaries. If the ovaries aren't excreting hormones anymore, then the idea to remove them while having surgery is to lower your risk for ovarian cancer. The same goes with the fallopian tubes, because now we know that the most common type of ovarian cancer, epithelial ovarian cancer, originates from the fallopian tubes. So that's why, and technically removing the fallopian tubes is fairly easy. So those are the issues why these are being discussed and charged. But if you are not at your menopause, then your ovaries would be kept, because you need them for your overall health in multiple ways throughout your whole lifespan.
Right. And we did get one question from a patient. She said she had her cervix, uterus, and fallopian tubes removed, but her ovaries were still intact. I'm not sure of her age, but she said for 3 months after the surgery, she experienced kind of menopausal symptoms, and then they went away. Any idea why there'd be that little time frame where she experienced that?
Yes. So it's very logical. This is due to the anatomy of ovarian blood vessels, because some of them need to be cut during hysterectomy. So the ovaries might malfunction for the first couple of months, or depending on the woman's age, whether her ovaries recover or whether then she would go into her natural menopause.
Right. And as far as getting hysterectomy or going through menopause with HLRCC, would there be any indication why hormone replacement therapy might be good or bad?
I don't see that HLRCC would change the situation from a typical situation with treating with subjective menopausal symptoms. But to have said, lacking the strong scientific evidence, we know of some sporadic fibroids that they do continue growing when HRT is started. But well, that's one of the reasons for routine checkups for some time, when you if you start with HRT, just to see how your fibroids behave to it. But then there's multiple products, so there's options.
Okay. Kind of switching up a little bit, we get a lot of patients that come in, they had a fibroid tested, they're FH deficient, and they need to go for further germline testing to see if it's HLRCC or not. It sounds like if it was HLRCC, the gynecologist would have seen many fibroids, as opposed to maybe these people, they just have one large fibroid that became sporadically FH deficient. Is that something that you'd expect to see, or you can't quite make that determination at that time? Obviously, germline testing will be the ultimate way to find out, but...
Yes. So you can have a mutation in an FH mutation in your fibroid without having HLRCC. But yes, I would recommend having a few gynecological checkups just to see, and be careful, because ultrasound is, it's equipment dependent, and it's also the clinician dependent. So the interpretation has some subjective approaches to it and some technical approaches. So, and it's only imaging. So to confirm the fibroid diagnosis, I think it's reasonable to have two or three checkups and ultrasound imaging, so that they are confirmed as well as it can be.
Yeah. We had a question. There's a woman, she had no plans of having kids at all. She's definitely younger, and she was wondering, does it just make sense to get a hysterectomy now instead of waiting for what seems like an inevitable outcome? What would kind of like the standard recommendation as far as that be?
I think it's really scaling between the symptoms and also the woman's age. And the uterus, it's not just an excess organ that it's that's how the pelvic anatomy is designed. And if your uterus is being removed, then during later your life, you are in a risk for a prolapse, for example, or some other issues with your urination or such. So in general, also your body weight affects these risks. Your family history affects. So generally, just of any surgery, I think the benefits should weigh more than the risks taken. So I think it really should be carefully thought, and only have removed an organ because it can't be undone, only when it's really necessary.
Yeah, that makes sense. As far as how you approach younger HLRCC patients with like family planning and timing of childbirth, there's definitely a lot of patients who feel like the doctors are being kind of paternalistic when they're like, you should think about having kids sooner, even though that might not be your plan. How do you kind of walk that balance of recommending what may be, a better plan as opposed to other?
Right. Yes. Very good question again. I think doctors' job is to give the information to patients, and they themselves decide what they do with their lives. So I think the women have the right to be acknowledged about their fibroids, and how what's their growth rate, and they should be told what the impact can be to their fertility. And one way to nicely set this is that when it's better sooner than later, but obviously it's not so straightforward. But I also think that when a couple makes a decision that they want to have children, I think there's also some rational thinking to it. It's not only an emotional decision.
Yeah.
So I think it's the it's according to evidence-based medicine that we provide our patients the most recent knowledge we have, and I think that's our job.
Yeah, I do want to get your opinion too, because we've used the word benign for these fibroids, and we use the same word for skin leiomyomas. And when you say benign, it kind of makes it seem like not so bad. What are your just thoughts on using the word benign, and if there's like a better term that we can use to describe these kind of very quality of life altering growths?
Right. So that's a good point. I guess we can split diseases into two: those that reduce the quality of life and those that reduce the length of life. I think during the, it's been said that the human maximum life expectancy has been reached because, all cancers and chronic diseases like cardiovascular disease, there's been huge developments in them. But now I think the focus has shifted to diseases that impact the quality of life. And that's why I think there's more focus on women's health issues as well, that many of them reduce the quality of life, and that can't be ignored. Infertility, for example, it's hugely impacts people's quality of life. So maybe we'll just have to figure out some other terminology, because there's sort of within pathogenesis, there's a clear distinction between benign and malignant.
Right. A big question in our group was definitely, are there any dietary supplement recommendations that might help or prevent the progression of fibroids, or just any lifestyle kind of changes that would be beneficial?
Right. I'm not aware of any dietary issues or supplements. There's no strong evidence of them. What's the issue of the amount of adipose tissue, so obesity, and their relation to fibroids? according to a fibroid meta-analysis, it's mostly the muscle mass that's associated with fibroids, but that's genetics. So obesity can be an environmental factor that impacts fibroid growth. And in terms of your general health or your broad health, I recommend to focus on healthy life habits. So
yeah, and I believe it was you that wrote the paper on muscle mass and fibroid connection. Yes. And you say, is that like if you work out a lot and you get a lot of muscle mass, it might influence it, or you said just genetically your general build?
So yes, our GWAS meta-analysis paper shows the genetic risk, not the environmental risk that so we can't say that if you work out a lot, then you'd increase the risk for fibroids. But genetically, some people are more prone to build their muscle mass, and it's the same that have the risk for fibroids.
Assumably because the fibroids are smooth muscle, your body's just set up for muscle growth.
So this brings a very interesting new perspective to start exploring fibroids and muscle biology, definitely.
Yeah, and I know you also specifically looked at cardiovascular risk factors and fibroid development, where it seemed like the serum lipids, like the LDL and the triglycerides, increased the prevalence. Would that be something that might be of relevance for HLRCC women?
So I don't have an answer to that. This is a birth cohort study with over 700 women with fibroids, but it's only registered data, so we can't differentiate if there were any women who had HLRCC. Again, that would be a very interesting area to explore. How HLRCC women differ with those who have sporadic fibroids, if they differ or not.
It's interesting because there was a study on a cholesterol lowering drug. It begins with an S. I can't think of its name right now, but it was looking at the reduction in leiomyomas. And it just seems like there would be an interesting correlation then between lower cholesterol and leiomyoma burden. I'm not sure if you were familiar with that at all.
No, I haven't seen that, but sounds really interesting.
Yeah,
so if you can find it, please send it to me. I have to look at it. Yes.
Yeah.
Yes, it's very interesting. Yeah.
So you also said you looked at endometriosis and comorbidity with fibroids. Is that like a two-way street, or is it the inflammation of endometriosis creates a more hospital environment for fibroids, or do the fibroids lead to endometriosis? How does that play out?
Right. We don't actually know the direction of the causality, but I guess we wrote it in the papers that way, that endometriosis patients are in risk for fibroids because the typical age to diagnose endometriosis is much younger than fibroids. But I don't even have any empirical knowledge whether HLRCC women with fibroids would be in risk for endometriosis. I can't remember any of the patients that I've seen that had endometriosis, but this is definitely something that should be looked at in the future.
Yeah, I can't say I've seen any posts on our Facebook page about people with endometriosis, but can't say for sure.
Yes, yes. Who knows? The symptoms overlap hugely.
Yes,
so
true.
Yeah.
Taking a more like kind of wide view, we already mentioned how women's health research has kind of historically been underfunded or understudied. How do you, someone work in the field, how do you view that progress in the recent years? And do you think more focus is needed, or are we at like a good level? What would you say?
No, I can't say that we'd be on a good level by now, but I think women's issues, women's rights, women's health issues, they're more spoken openly. The focus is there, and I'm hoping in the future that there'd be more research funding to women's health issues. That's one of the key issues to get the funding. So yes, I'm optimistic. So yes, hopefully, and well, we need the funding, we need the researchers, we need the ideas, we need patience.
Yeah, everything. You need everything.
Yes, yes.
So on that note, if you had unlimited funding and unlimited resources, what kind of research into HLRCC associated fibroids would you prioritize?
Yeah, this is a nice question. I think I'd set up a cohort and a biobank for these patients. I'd also like to contact them and create a questionnaire-based study for them as well. But I think in general, if there was, limitless funding, I would do the patient recruitment systematically. So every time a patient contacts a health center, the electronic systems, maybe using AI, would scan all the studies that are ongoing in the center, and then they would, recommend you would fit to a patient. They would recommend you would fit to this trial or this one, and please read the information sheet, and if you're interested, contact the research nurse. So yes, I think we could be more efficient with the recruiting patients.
Yeah. Are there any specific scientific advances in the field that you're excited for, or like are kind of on the horizon that you think might be, I don't want to say game changers, but significant advances?
Yeah, so I think our GWAS meta-analysis paper on fibroids and the muscle mass is very interesting. So genetic epidemiology is basic research, and we need to do a lot more work. But this really gives us a hypothesis, so a direction where to go to. And if we look back to 20 years ago, we've taken huge steps in medicine. So I like to think towards future that also, after 10 years, 20 years, we've continued taking those huge steps. So I'm optimistic, but yes, future will tell.
What are you currently working on? Anything HLRCC specific?
Yeah, so well, when the alliance was set up, and this does create new enthusiasm and new ideas, I think we need to go through all the HLRCC patients here in Finland. That's what we can do, and increase the sample size from the previous, and maybe put together consortiums between an international consortium, so put our strengths together. So definitely all these opportunities, when they bring us to the subject, I think it creates ideas, and it creates connections and collaboration.
Yeah, the HLRC Alliance should go a long way in kind of helping everybody in that case. I do want to ask too, when we talk about conventional fibroids, I get the sense that we're usually talking about Caucasian or white population, and it's known that within the Black population that fibroids do show up earlier, they are more severe. And so what recommendations would you give for Black HLRCC women who are having bad fibroids, and maybe doctors are not taking the idea of a possible HLRCC diagnosis into play because it doesn't seem abnormal for them to have these more severe symptoms?
Yes, very good question again. I'm not very familiar with your setup, but if I understand correct, if your answer is that if you're not happy with your doctor's judgment, this is what I've been thinking about when we've had calls in the HLRCC Alliance, that if there was like a patient specific document, general information that you can find easily by Googling, because if you have the positive family history, it would give a hint to your doctor. Yes, but this is a clinician's everyday life. We need to be updating our knowledge on a weekly basis, and it is a challenge with exponentially increasing data. But that would be one concrete way to have your doctor sort of direct the right way and have you checked up.
Yeah, and so we talked about finding good doctors. Fibroids are very common. Are most gynecologists set up to treat fibroids, or is it definitely more of like a specialty where you have to kind of hunt down the experts in fibroid treatment?
Right. Well, among gynecologists, I don't think you can find any gynecology in the world who hasn't treated fibroids. They're so common. Between 30 and 70%, or even higher, is the prevalence rate. Depending on the country where you live, what the setup is, I know they differ. But it's more of general gynecology, so the name tells it all. Depending on, if you are considering surgical treatment, then you might be directed towards a surgical gynecologist, or someone who does myomectomies or who has more experience of uterine artery embolization. That's collaboration with radiologists.
Okay.
But I think it's general, but yeah, it's just the knowledge of this rare syndrome and how which organs it manifests, and how you can have your gene test done. So I think it's about that.
When you go to the conferences with other gynecologists, what's your sense of their level of knowledge that HLRCC even exists, or have you seen it become more of a, I won't say well-known condition, but it's not like a surprise when people hear about it?
I think many gynecologists are aware, but there are some who are not. But this is something to take into consideration when textbooks are reviewed or rewritten. It's good to keep this in mind. And so on my first paper on HLRCC, that was exactly my idea, that the gynecologist can be the one who suspects HLRCC, even though the uterine manifestation is benign. This exactly. So I think gynecologists have a significant role in diagnosing and reviewing these patients.
Yeah, I know the screening recommendations vary from country to country. I want to say that usually they recommend annual ultrasound screening around the age of 18. Is that what you would say is about true?
So at the start, when you're being diagnosed either with multiple fibroids or with HLRCC, I think it's a good idea to have scans maybe a few months apart, so that we can see the growth rate of the suspected fibroids. But then it really depends on your symptoms and your wish to conceive, and then your age. So the diagnostic question is a bit different every time. So yes, maybe not every year throughout your whole life, or even not until menopause, but and the best way is to be reviewed by the same gynecologist who is aware of HLRCC and who scans you carefully and makes careful documentations.
Yeah, because that's what I was going to say, where when it gives these broad recommendations of annual ultrasounds, if you're not symptomatic, the information on the ultrasound isn't really as relevant as opposed to like renal MRIs where we're looking for malignant growths. That's not something we're really concerned about in this case. And so you would say it's more like a symptom or what your future goals are, sort of thing.
Yes, yeah, but it's also a clinical question on the how frequently the follow-ups should take place.